people coming in at 11:45 and to start off our session. So all of you people who have joined early get to hear my brief introduction before we actually get started on the sessions itself. So I want to say welcome to all and to those who tune in a few minutes to our 2021 Texas Business Group on Health Benefits Forum. The title is called Back to the Future. So what we chose is kind of the back to the future of a new normal, the workplace and work life, given the disruptions of COVID over over a year and a half now. And we had high hopes to host this year's forum in person in Houston and in San Antonio, as we've done for probably the previous 10 years, except for last year was our first virtual one. But as we know, concerns about the new COVID Delta strain and still uncertainty among many employers and their employees about returning to work in person, we decided to go virtual again this year. Now, the downside is that we don't get to see any more than a virtual picture of the speakers, and we don't get to see all of you who are attending and interact with you and see kind of the facial expressions, happy or sad or whatever, and or puzzled. But the good news is that the benefits professionals from all over the state can attend this event, and we actually do have some from all over the state without having to travel any further than your computers. And the main focus of this year's forum is on forward-looking benefits adapted to a post-pandemic work life and workplace. The forum features 4 sessions, which are shown here on the slide, 2 per day, today and tomorrow. The sessions will be recorded and made available to everyone who has registered afterwards. So if you want to miss something of one and want to come back to, or miss one of the sessions and want to come back to it, you'll have access to that afterwards. We're really grateful to our 10 sponsors who are making it possible for us to offer this valuable educational program to employers across the state, including members of our 3 Texas coalitions, TBGH coalitions, Dallas-Fort Worth Business Group on Health, the Houston Business Coalition on Health, and the San Antonio Business Group on Health. And to show our appreciation for the support, we've offered each sponsor an opportunity to showcase their company's services and resources just for a few minutes between each session. So with that, I'd like to, before we start the first session, I want to recognize and thank AbbVie and our AbbVie account manager, Suzanne Goot, who has partnered with us for many years. And Suzanne was asked to share this short video. So sit back and listen up then for an interesting video, rather than a talking head. Here we go. Well, that's a happy video. So thank you, Suzanne, for sharing that. I feel good already. Feel good for the rest of the day to see all those happy faces and the good work that Abby is doing. So let's get started on our very first session. And this one is called Advanced Primary Care at the Epicenter of Healthcare's Future. Advanced primary care will be abbreviated as APC. Of course, this is healthcare. There's abbreviations for everything. So that's what the new one is for advanced primary care. It holds great promise for employers to improve employee health outcomes, and healthcare costs. So I'm really excited that my colleague, Chris Skizik, the Executive Director of the Houston Business Group on Health, brought this to us. He serves on the board of directors of the Texas Business Group on Health. And just a quick word about Chris, so he doesn't have to introduce himself and you don't have to read the tiny print on the slide. The Houston Business Coalition on Health is an 85-member organization representing more than 800,000 local employees and dependents and more than 2 million covered lives nationally. Chris also serves on the Board of Governors and Executive Committee of the National Alliance of Healthcare Purchasing Coalitions, which is the umbrella coalition of all the different coalitions like the Dallas-Fort Worth Business Group, the Houston Business Coalition, the San Antonio Business Group, Texas Business Group. And he, as I said, he's also on the Board of Directors of the Texas Business Group on Health. He serves on several leadership councils in Houston, very active. Houston City's Changing Diabetes and Houston Social Determinants of Health. And we call him Dr. Chris Skizik once in a while because he has earned his PhD from the University of Texas School of Public Health. So Chris has put together an amazing panel of experts in this new model, the APC model, the Advanced Primary Care model. And I have not heard them speak before, but I know a little bit about their organization, so I'm so excited to hear this. I will tell all of you who are participating as attendees in this to please ask questions and interact with the panelists through the Q&A box or the chat box, or both. So we'll be monitoring that throughout this presentation. And actually, Chris, you've got an extra 5 minutes. We're speeding right through this, so I turn it over to you.
Well, thank you. Thank you. We do these sessions every year, TBGH, and typically one is in Houston, and we kind of design that session. And I'm usually not a moderator for these, but I believe so strongly in what we're about to discuss that I wanted to have the privilege of moderating this session. HBCH, we call it our North Star, and we think this is the real value opportunity for employers going forward. And our North Star consists of 3 elements that are all interconnected. Advanced primary care is one of them. So we'll be focusing on that. But we'll also touch a little bit about the integration of behavioral health into primary care. We believe that is so critical as well to produce better health outcomes. And then also the referral strategy, and when one needs specialists, how is that done? So what we have today are 3 physician leaders that I have known for several years, all providing different nuanced varieties of advanced primary care. So we're going to hear quite a bit, and I'll let these folks introduce themselves in a bit more. But we have Dr. Clive Fields, who's the Chief Medical Officer and co-founder of Village MD. We have Dr. Juliet Breeze, who is the CEO of Next Level Urgent Care, with, I don't know, 15 and growing clinics around the Houston market. And finally, we have Dr. Pat Carter, who I've known for several years, and his focus on advanced primary care through his leadership roles at Kelsey-Seybold are commended, and they are a strategic partner of HBCH. Last and certainly not least, we have Andrea Cockrell, because we want to get that employer perspective, and we're going to be asking her to comment and ask questions. Andrea leads the benefits for the city of Plano. So we've got a real nice mix here. And so what I'd like to be able to do now, and maybe just start from top to bottom, is have each of our panelists introduce themselves. So Clive, I'd like you to just talk a little bit about how you came to be a PCP, and then a little bit about your organization as well. Take a few minutes, and then we'll go to Juliet, Pat, and then Andrea.
Sure. Thanks, Chris. Thanks for the opportunity to talk to your audience today. So I am a practicing family doc. I've worked in Houston for about 30 years now, and was very fortunate in the mid-90s to be introduced to what was then called Medicare Plus Choice, but is now kind of the predecessor of Medicare Plus or Medicare Advantage, and ultimately introduced to value-based care. And what we saw very early on in the growth of my organization is that the results that we had in our organization looked a little bit different than many of the smaller groups at the time in the city of Houston. And to be honest, it was because my father, who had founded Village Family Practice in 1975, had been trained in Scotland and practiced in Canada, two countries with national healthcare systems. And in those systems, people have a primary care doctor. Not everybody with a pimple goes to a dermatologist. Not everybody with back pain goes to an orthopedic surgeon. And he really taught myself and the other young doctors that joined us to practice in that fashion. So when you talk about back to the future, I go home all the time. I tell my dad all the wonderful things that we're doing in advanced primary care, and he looks at me a little bit inquisitively and he says, "Son, we used to do that." And the answer is they did. They just didn't do it with scale and with technology and with the ability to really measure the impact of their work. I mean, ultimately, our practice grew to two sites and 13 doctors. And in 2013, we thought we were a pretty big deal. Unfortunately, we were the only people who thought we were a pretty big deal. And as a result, we made the decision to take what we had formed as our clinical model and take that, raise some capital and go out and share it with other family physicians. So really pleased now to be able to say we're working with over 3,000 physicians in 15 states, taking care of about 1.6 million people or patients. And more importantly, we'll end this year with about 51 locations in the city of Houston, delivering what we believe is the best type of medicine, which is accessing primary care or accessing the healthcare system through a trusted provider, a trusted physician, a primary care physician. So thanks again, Chris, for letting me join today.
As we go to Juliet next, I was thinking we're not necessarily saying go back to the Marcus Welby days, and for those who are younger, ask your parents who Marcus Welby was. But with that, Juliet, you want to go next?
Sure, Chris. Thank you so much for having me here today, and excited to be on this panel with Clive and Patrick, both of whom are my personal heroes for what they're doing. I started my career, it's been a little different. I was a practicing PCP for about 5 years, and then I really loved that opportunity to be the person who is partnering with patients on their sort of healthcare journey. But when I really got into practice, there were so many things about the healthcare system in general that really just bothered me. How we practice medicine here, and the strange way that we're compensated for the care that we give. And so I ended up turning my interest to more of sort of the business of medicine. I opened several different types of practices. I cut my teeth on a lot of different areas of medical practice. And ultimately I got inspired to create a business, which is Next Level Urgent Care. And that business was created in response to what I felt was a problem in Houston, growing number of freestanding emergency rooms that were charging really exorbitant rates for things that people generally would have seen their PCP for if their PCP was open. And so I decided, okay, let me see if I can put up centers that are open extended hours, open 7 days a week, able to accommodate those things without charging an arm and a leg. And So the sort of mission of Next Level was to provide high access, high quality, and affordable care. Well, over the years, that we are following that same path, but we've added services, and we have begun to realize that we can actually make an impact in the primary care, preventive care world as well. And so now we have sort of added another layer to what we do. We certainly still provide our urgent care, and actually we have 20 locations that are accessible to anyone in Houston. And then we have another 6 clinics that are owned by employers that we manage. And we have 5 more under construction in Houston, and we're moving to San Antonio and Austin here in this next 12 months. So it's an exciting time for the company as we promote what now I think you're calling advanced primary care, and an opportunity for employers to purchase directly from us membership medicine that allows their employees to come to us for zero out of pocket for everything that they would do, with preventive, primary, and urgent care. So that's who we are as a company.
Thank you, Juliet. And I think I indicated we work closely with all 3 of these organizations and support their missions just because of their focus on advanced primary care and what we're trying to do collectively in Houston. So next, I'd like to go to Pat Carter, and longevity. We probably had that relationship longer than others, but I was a Kelsey-Seybold client and till I moved out of the area, and I'm on Medicare, so I can't use them anymore. But they were my personal physician for 30 some years, and I've always been impressed with what Kelsey-Seybold is able to do. So Pat, you want to talk a little bit about yourself?
I will. Thanks, Chris. So I'm Pat Carter. I'm a family physician and geriatrician. I still practice medicine too. And I'm at Kelsey-Seybold Clinic. I'll talk about Kelsey in a bit. When Chris started, he said, well, why did you become a PCP? I will tell this little story that I was an Army doctor before I came to Houston. So I was in the military for 10 years. And when I was in medical school, I was on an Army scholarship, and I really didn't know what sort of specialty I wanted to do. I was the first doctor in my family, so I didn't have somebody telling me to do whatever Dad did. But they sent me to Germany. So I got sent to Germany between my 2nd and 3rd year of medical school. And they had me shadow basically a family physician in Würzburg, Germany for 6 weeks. And when I saw him and the sort of care he took of his patients and how much they appreciated him, and sort of the variety of stuff that comes through the door when you're a family physician, I said, okay, well, that's what I want to be. So that's how I wound up being a family doctor. And then later, when I got out of the Army, I had this golden opportunity land in my lap to go to business school at Stanford. I was just down the road at the time. And I had a mentor there named Alan Enthoven, who was a big healthcare economist and a big fan of the Kaiser Permanente system out in California. And so I sort of got indoctrinated into capitated practice, multi-specialty group practice, and all that sort of dovetails with the idea of advanced primary care. So I wound up answering an ad in the New England Journal for a clinic called Kelsey-Seybold Clinic, which I'd never heard of, and I'd never been to Houston before. So this is in '94. I came in as the chief of family medicine, and so now been there 27 years. We are a big clinic in Houston. If you don't know about us, we are currently 27 locations, and we're adding about 10 more locations in the coming year. We do a lot of capitated practice, which we'll probably talk about a little bit in our discussion here today. And again, it's a multi-specialty group practice. So I feel like I've got all the support in the world surrounding me. So as we all know, as primary care physicians, you'll see patients, no matter how experienced you are, no matter how smart you are, how much you know, almost every day something's going to come through the door you don't know what to do with. So it's very handy to have all my colleagues around me to help me out on that. So with that, I will stop talking, and I'm looking forward to the discussion.
Thank you, Pat. And then last, of course, not a physician, but a key part of our panel is Andrea Cockrell, who I've known for several years now. We served together on the TBGH board. And Andrea, what I'd like you to talk a little bit about your background, but I know you are working on this in the market, and just how important is healthcare to your organization? We don't have to get into the primary care piece. We're going to get into that, but the attention that you're paying to it now and why this is important.
Sure. Yeah, so thank you for having me on the panel. They said we've got three really smart people that are going to know a lot. We want somebody to balance out the education level. So here I am. Anyways, I worked for City of Plano for 11 years, and I actually started as the controller. And at some point, the HR director said, we really need to take a better look at our, healthcare, our health plans, pay more attention to it. So do you think you'd be interested in doing that? So that's kind of how I transitioned. And to me, the first thing that we did back in, I don't know, 2013, something like that, was we had abysmal percentages in terms of primary care engagement. So that was like our first task. And so I think it's so important. And it's, a requirement for every adult on the plan to get a primary care exam, or they pay a higher premium. And even just anecdotally, we took a year off last year due to COVID, and I feel like we are kind of paid the price a little bit this year. People put off their health, and you can tell, because this year's been a horrible year, financially and just in general. But yes, I think it's very important, and to make it as easy as possible for people to develop relationships with primary care physicians.
Thank you, Andrea. Well, I guess now we can start getting into the meat of our discussion. So I put this infographic up here, and it's tough to see all of the writing. So I'll kind of navigate this, but this was a placement, if you will, produced by the National Alliance of Healthcare Purchaser Coalitions. And again, HBCH is a member of that organization, representing about 60 million employer-sponsored lives around the country. But it creates the need right here for advanced primary care. And what is that? I mean, how do we define what advanced primary care is? What we do know is and I got a chuckle out of this, U.S. adults who have a primary care physician have a 33% lower healthcare costs and a 19% lower odds of dying. I found that interesting because I still think it's at 100%, but I'm sure that's put into context here, and there's real value in it. But what makes this? And there's 7 key attributes, and we're not going to address all of them, but I'm going to ask our panel to look at these. In particular, the access is critical. That 24/7 access or real-time access, more time with patients, that has to be part of the model. You can't do advanced primary care in 15-minute increments. You just can't. A realigned payment model, getting away totally from a fee-for-service model to a, we don't want to call it capitated, we're calling it population-based payment model. Capitated kind of has that negative connotation of the old HMO days, and that's not what that is. But and also the referral management to specialists, but we'll touch on all of these. So what I'd like to, and there's no special order for our panelists, I asked you to take a look at this infographic, and if you might comment on how you see this, where your organization is today, and perhaps where it's going in the future based on the population focus, the patient-centered focus on this. So anyone just care to comment on this infographic and how it describes where you're at or where you're going.
So Chris, I'll jump in first. And I think what's interesting is I don't think any of the docs on this call will disagree with any of this. We've needed an aligned payment model that supports health and wellness instead of sick and sickness for a really, really long time. And I'm hoping the folks on this call that are in the business of choosing benefits recognize that without a continuing focus and investment in primary care, there's absolutely no opportunity to change the trajectory of cost or the patient and provider experience. I mean, at Village, we think of advanced primary care as proactive, risk stratified, and team-based. And that sounds like kind of those words that people throw out. But if you think about it, access is clearly a part of advanced primary care. And you think about Juliet's model and how she's really improved access across 365 days for extended hours. But when you think about primary care, a lot of what we do, and I think I suspect Pat does a lot of the same, is we used to wait around for people to wake up and decide they needed to go to the doctor's office. And I'll be honest, the majority of time, it's not the right people to make that decision to go to the doctor's office. So we truly believe that having access to a 360-degree patient medical history, claims histories, EMR histories, hospital discharge summaries, allows us to risk stratify and actually engage those patients who are most at need of primary care. Like most businesses, 80% of the cost being driven by 20% of the patient. We think the ability to risk stratify patients, to be proactive in our outreach, and to not have only the primary care doctor as the single source of care delivery is ultimately how we think advanced primary care will move forward.
Anybody else?
I'll pipe up there. Yeah, I agree with, as Clive said, I think we're probably going to agree. It'll be very monotonous because we're all going to agree with each other all the time. But yeah, the way I see it, you probably all heard the terms accountable care organization. You may have heard the term medical home. This all kind of goes with that. I think that, again, when I came to Kelsey-Seybold, I was attracted by the idea it was a multi-specialty group practice. So we all kind of worked together, had the same medical record. Now it's electronic, that we did have the ability to take care of populations. So yeah, in the traditional primary care model, as Clive said, you would sit there in your office and you take care of whoever walked in the door, which, some patients are really good. You'll say, oh, they're the compliant patients. They're the ones who do what we want them to do. They come in, they don't have to be reminded all that. Well, most people aren't like that. That's just not the way people work. So the problem with the traditional primary care model, at least one part of it, was that there really wasn't any outreach to the population who is supposedly coming to this doctor. So all of us in medicine know we have patients that, they may have very significant diseases, stuff that will kill you or cause you to, not be healthy, will cost you a lot of money. And a lot of patients just, the last thing they want to do is come into the doctor and talk about those particular diseases. So the outreach to a population of patients, which, we call disease management or case management, I call it organized professional nagging. It's to identify folks who aren't coming in and kind of plead with them and suggest ways and offer them appointments and get them to come in. So I feel like in an advanced primary care model, it's not just me sitting there in my office waiting for somebody to come in. I've got this entire infrastructure around me that is really designed to monitor a population of patients, not just my patients, but all of my colleagues at Kelsey-Seybold. And I think that's the right way to take care of folks. I do think I know it helps to reduce long-term costs, including all sorts of costs, not just outpatient costs, but also inpatient costs, also pharmaceutical costs, that sort of stuff. It increases patient satisfaction. People want to be able to contact their doctor, 24/7. We can do that with video visits and e-visits, and we have a 24-hour call center, nurse access line. And we also improve our quality. So if you want to have a high quality care of a given population, you really have to be reaching out to them all the time. Again, doing all the reminders, making sure they're getting their testing, not only for whatever chronic diseases they have, but also make sure they're getting their health maintenance testing and all that. So it's it requires a good organization. I think the three of us all are fortunately parts of good organizations. And but that I think is sort of my overall view of it.
Thanks. Juliet?
Yeah, I'll jump in for just a second with a couple of observations from my perspective, which is just a little nuanced difference. When we started with urgent care only, the first question we ask every patient when they walk in the door is, do you have a primary care doctor? Because we are very committed to getting notes to primary care doctors for people who see us. Well, what was fascinating was greater than 55% of the people using us told us that they did not have a primary care doctor. Then later on, as we were going along, and we got into primary care through an opportunity that we had to work for a county. So we became the on-site care provider for a county. And observations, which kind of echo what Pat says, is this group of people had care for free at their on-site clinic. And we saw that people, first of all, cost what was a barrier. And when it was removed as a barrier, they did take a little bit better care of themselves. The other thing that we saw was that we launched the on-site clinic with a health risk assessment. And as Pat and Clive both said, that the outreach to the highest risk people really became something that really bent the cost curve, because we were, really trying to identify those people who were in need of the services. And so the thing that I think is not necessarily spelled out on this infographic that I think maybe should be is the care navigation piece. And I guess maybe that has to do a little bit with referral management, but what we see it as a healthcare is so confusing, and people don't even know where to go for what they have. And so I think each of our organizations is trying to make it very easy for patients to, with a click of a button, get to somebody who can help them, even understand whether their problem or question is necessary to have anybody see them. And so those are things that I think we're bringing into advanced primary care. It's more of a total patient, guidance and support versus just, as Clive said, patient decides they're sick today and they call. We're really trying to take that a step further. So in this infographic, I think all of these things are so vitally important to the practice, but I would emphasize that without the outreach and without the opportunity for people to get somebody to help them when they need it, I think it all falls apart.
Yeah. Well said, and we'll touch on that a bit more. Andrea, you don't get off the hook on this one. I know that the city of Plano recently signed a contract with I believe it's Catalyst Health, Dr. Chris Crow's group in the Dallas market, who I know Clive knows well. When you look at this infographic, and as you are working with Catalyst, do you see some of those same attributes that Pat, Juliet, and Clive have talked about?
Yeah, yes, absolutely. And let me, I guess, pause and just share what we do at City of Plano. So we had thought a lot about, we always felt like primary care was important and we wanted to eliminate barriers, but we're pretty spread out, and a lot of our employees don't live in Plano. So we kind of started small, and there's a group called Village Health Partners in Plano that was a group of primary care physicians that had a couple of locations, and we started by partnering with them. And we just sat down with them and said, here's what we're trying to accomplish. Do you think you can help? And a lot of our people were already going there. So we have kind of a modified advanced primary care model. We have a $5 copay for Village Health Partners. So it's different than the rest of our providers. And then as time progressed, so people that go there really like it. But if you live, maybe an hour away from Plano, like if you're a firefighter, and some of them live very far away, they tend to go where they live. So we needed more options. So that's when we expanded to Catalyst, because that brought in more PCPs, and they use that same approach and outreach. If they're focused on the individuals who have the highest risk profile, they're focused on the whole well-being, including behavioral health, and they're outreaching to those individuals, integrating pharmacy to make sure those people that cost your plan the most money are getting the care, and then just gentle reminders for the rest of the population. They maybe just need an annual check-in. So that's kind of what we do. We do not do the you know, the service where it's like a, I don't know what you call it, a set amount each month. We're government, we're very risk averse. So we're usually not leaders on things like that. But I personally can say that we've only had one premium increase, I think, in 11 years. And I don't know if that's, I don't know if that's attributable to the engagement in primary care, but I like to think it has a little bit to do with it. So that's helped keep our costs down and keep people healthy.
Thanks, Andrea. We've got a lot of good questions coming in. This may be just a nod of heads or a yay, I agree. One of the questions that came in was, is advanced primary care, is that the same as a medical home? Do you see this? Do you see those as, to me, a medical home is where one goes, but advanced primary care is how you practice.
Yeah, I can comment on that, Chris. So there's a certification for medical home through, I think it's NCQA, if they're still doing it, but a lot of the elements that it takes to be certified as a medical home are actually the same thing that's on your infographic there. It has to do with what we were talking about before, the idea that a medical home is not only where patients come for their first encounter and ongoing encounters with the healthcare system, but medical home is also designed to keep track of the patients who are supposed to be coming to you. So it includes that outreach portion. It includes that advanced access portion where people can get in contact with you at all hours of the day and night. So yeah, it's very similar.
Fantastic. Anybody else? Everybody in agreement that the medical home APC are one and the same? Let me go to another question for our physicians, and ironically, Dr. Carter was on a panel that HBCH hosted on quality, and we had Dr. Brent James, who is now with the Stanford Clinical Excellence. He's in the School of Medicine there, but he was real instrumental in developing a lot of Intermountain Health's value proposition. And I just remember the one slide that he showed and bantered about, that waste in the system is about 20 to 40%. Things that don't need to be done, things that are done improperly, and related to that, the fee-for-service model proliferates that waste in large part. In fact, Pat, you mentioned Alan Enthoven. I actually put an article in our newsletter last week about this same topic, and how employers, by working through a fee-for-service model, are knowingly or unknowingly proliferating a lot of the problem that we have right now. So my question to you is from your perspective, why do you think this capitated population-based payment model is superior to the traditional PPO fee-for-service model? And you can all jump in as you want.
Yeah, Chris, I'll take that. I mean, the idea of what we believe in, we are rapidly moving to what we call global capitation, where we take a single check and are responsible for all medical costs associated with an attributed patient. The idea that primary care doctors are going to go to the bank and borrow a bunch of money to actually invest in an infrastructure to do the types of things that we've all agreed need to be done is somewhat ridiculous. And so there are very, very few organizations that would do that, and certainly individual physicians or small practices are not one of those. So the move to a capitated or a population-based payment does a couple of things. It allows physicians to invest in an infrastructure to deliver advanced primary care, but just as importantly, it aligns incentives with employers and patients, which are focused on creating and maintaining good health instead of sustaining, unfortunately, illness and disease. If I take my car to get a new tire today and it breaks tomorrow and I take it back, I can assure you I will not expect, or I will not be expected to pay for another tire. But if you see me on Monday and I make a bad diagnosis, you see me on Tuesday and I haven't figured it out, you see me on Wednesday, good news for me is I get paid 3 times. Bad news for you is that you pay 3 times. And so it's an alignment of economics that allows us to focus on what we believe are ultimately in the best interests of patients and employers, those who pay for healthcare, which is to focus on prevention and wellness, and to focus on patients with chronic disease that are truly consuming the vast majority of the healthcare dollars. So we don't see any other option, and we would urge all of those on the call who are employers who are choosing healthcare to think about how you actually pay your physicians, because the one thing that we know is if you want to change the way healthcare is delivered, change the way healthcare is paid for.
Got that right.
I couldn't agree more, and just want to chime in that it is very freeing as a physician to not have to beg for payment from an insurance carrier to do the right thing for a patient. It is also really hard when you're talking about itemized billing and the fee-for-service world, trying to explain to a patient why they need certain things, because then all of a sudden it's not about what's the right thing for the patient, it's about who's paying and what they can afford. And so when we moved into the membership model, it was so incredible. My doctors all of a sudden could just do the right thing, and the patient never took their wallet out, so they never had a reason to say, oh wait, I don't want that x-ray because I can't afford it. And so I think that we practice better medicine and we do the right things. It's a wonderful model. I'm not sure why everyone is, well, I do know why everybody doesn't want to do it. It's, you can make a lot more money if you charge everybody for everything, but that's not really why any of us became doctors. I think we all really want to see people have better health, and that's the way to do it, is to take that fee for service out of it.
No,
Yeah, I agree.
I was going to say, Pat, with Kelsey, they are fee for service, but they are at risk for that capitation. So Pat, if you kind of explain that nuance a bit.
Well, I'll tell you, you mentioned earlier, Chris, that a lot of healthcare economists quote that 20 to 40% of healthcare provided in America is waste, and I think it comes from the fee-for-service system. So the doctors that start at Kelsey, one of the ways we torture them when they start with us is they have to listen to me drone on for 3 hours about this particular topic. And so I always use the example, well, I'm a family doctor. That's sort of the cheapest form of physician. And if somebody comes in to see me in the office and say they have a cold, something typically your mom could diagnose and take care of, I could pat you on the head and say, hey, it's going to get better. Take some Tylenol, call me if these things happen. And the cost of the visit would be, whatever my office visit charge is, reasonable charge. Or I could go and order everything on the menu in my electronic medical record and get a chest x-ray, get blood work, get a throat culture, all sorts of stuff, which in this case probably is not necessary. The thing that doctors in a fee-for-service environment deal with, and I'm not blaming them, but doctors, like everybody else, they respond to financial incentives, is that office visit code is not very profitable. It barely covers your expenses. The chest x-ray and the blood work and throat culture and all that sort of stuff, they are quite well compensated. So it's very profitable to do a bunch of tests, which in this case are not necessary. And when you multiply that by tens of thousands of physicians and some very high priced specialists, people that can do scopes and caths and all kinds of stuff, you really run into a big overutilization of care that's not necessary. So it's not evidence-based, it's unnecessary. That's where the waste in healthcare comes from. Kelsey-Seybold, as I mentioned, one reason I came to Kelsey-Seybold is we've been doing capitation since back in the 80s. And for those of you who are not familiar with it, it's in our case, most of our contracts are called professional capitation. So we get a certain amount per member per month, and we take care of all professional services for those patients. It's not just the care we provide at Kelsey, but if they go to an emergency room, they get admitted. We have affiliates, actually, Dr. Breeze's urgent care clinics are one of our affiliates, but we pay other doctors to do the care. But it's all, we're at risk for that whole thing. So it transfers the risk onto the medical group. We are the ones best able to control costs. We're the ones best able to control the utilization and to make sure that our patients are being taken care of in an evidence-based, cost-effective way. So we are similar, to other big groups. I mentioned Kaiser Permanente, but Scott and White Clinic and places like that have done capitation for years. And if it's done right, which I think we are, to me, it is the best way to take care of patients. And Clive mentioned the global capitation. We already do that as well. We actually, in Medicare Advantage, we are globally capitated, which means we are responsible for paying all the bills. But the end result is that by practicing evidence-based, cost-effective care, you really can control total medical costs to the tune of, we show anywhere from 15 to 30% savings compared to the general kind of population of physicians in Houston.
Andrea, in your model, are you fee for service, or are you population-based payment, or somewhere in between there?
So we just pay fee for service. So the only thing that we do that's unique is that we have lowered our copay to steer people to particular providers. And,
yeah.
I mean, I think that's somewhat of the challenge, but when we transitioned last year, but we had United Healthcare and an ASO plan, and I know that their contract, I believe, offered some sort of incentive to primary care groups like this, and they are looking at things that they're doing in terms of their outreach and integration, and so it's somewhat embedded in that aspect of things. But I think that's kind of the challenge as the employer is, let's be honest, nobody wants, like, a lot of people don't want to be the leader on this, and they want to see some evidence of this working elsewhere, and they don't want to be taking what they might perceive to be financial risk.
Yeah.
So
totally understand, and let me comment on that. It is tough. I truly believe that this is the future. By the way, all three of these physicians anyway, and Andrew, we invite you too. We're going to host our conference on December 8th, and we're going to explore this a little bit further with all three of these groups. But we call it employer price discrimination. And what we mean by that, if you look at the price employers typically pay relative as a percentage of Medicare for typical services, employers are paying somewhere between 2 and 7 times, depending on where you are at in the country. In Texas, we're about 2.5 times that Medicare rate. And what we're saying is that this impacts the business directly, growth in particular. It certainly impacts the quality of life of their covered lives, because of the amount paid leaves less for other things such as retirement, kids' educations, and so forth. But on a larger perspective, we think it impacts the greater community. And Pat mentioned a second ago, they're totally capitated for Medicare Advantage, and I think the wish of a lot of employers, or at least the folks who are in the space, wish that all medicine was practiced with equity in mind. And what I mean by that, the quality of care you get for Medicare should be similar to the quality of care that you get in the commercial market, should be similar to the quality of care that you get in Medicaid. and should be similar for those that are uninsured and can't pay. We're nowhere close to that right now. Won't ask to comment on that. I just wanted to verbalize my own perspective. So I want to move to another topic. HBCH is one of 8 coalitions around the country that are involved in what's called the Path Forward for Mental Health. The Path Forward for Mental Health is looking at access, looking at parity, looking at the use of telemedicine, looking at the use of measurement-based care, looking at the collaborative care model, which has its own unique features. When we survey our members for the last few years, we say, what's the biggest chronic condition we can help you with or that you need support in? And it's mental health. And we see that through COVID, this has really raised this issue. So I would like to ask, how are each of your organizations looking at the integration of behavioral health now and in the future? I know some of you do it with Medicare because it's part of it. I mean, you can do this, but more for the commercial market, if you could each comment on that a bit.
Yeah, it's interesting. People talk about the integration of behavioral health and primary care, and it's a little bit like case and care management. It feels like those industries came up as a result of failures inside primary care. Because if primary care is doing a really good job and they're team-based and proactive and risk stratified, then care and case management, disease management becomes part of what they do. So much of primary care is delivered with, so much of behavioral health is delivered within primary care that I think we have the opportunity to make somewhat small changes in the system to deliver really significant results. And we think about the Medicare population, and we think about dementia and delirium and other conditions. We think about the commercial population. We focus more on kids with ADHD or anxiety and depression or drug and alcohol abuse. But in all of those areas, to center the care around a primary care physician that understands the 360 degrees of your entire holistic kind of being is certainly better than trying to silo out a doctor for schizophrenia, a doctor for depression, a doctor for your kids to see for ADD, and another doctor to manage your hypertension and diabetes, because they just don't separate out really well. And what we know is that medical costs in people with chronic disease are significantly increased when you have a comorbidity, a behavioral health comorbidity. So at Village, we had started really with the collaborative care model, which was really embedding behavioralists inside primary care clinics. And like a lot of parts of medicine, I was pretty disrupted about 18 months ago. And most of that has now moved to a virtual platform. So when you talk about telehealth, and I think it came up early on in the introduction, telehealth is not a provider. Telehealth is a platform for your provider to reach outside of his office or her office and achieve both scale and convenience and access. So I was actually thinking that I don't think anybody thinks that Apple is their phone provider. They think of Verizon or AT&T. So we think of the same way. So your primary care doctor is Verizon, Apple is your telehealth provider or your telehealth platform, but the two don't necessarily accomplish the same task. So we think that embedding behavioralists inside primary care inside primary care clinics, but during COVID, accessing behavioral through a telehealth platform makes a lot of sense. COVID's going to have a lot of long-term implications, and we're going to talk for a long time about the late diagnosis of cancer and the delay in colonoscopies and mammograms. But one of the most striking things are the anticipated 75,000 people who will die from suicide between now and 2027 as a result of COVID-related anxiety and depression. So it's something that's going to be with us for a while. We think primary care is absolutely the place where people should access, be directed, and be supported through their behavioral health problems. And embedding or reaching behavioralists through a virtual platform, it's worked well for us. We wish there was more skilled behavioralists available to meet our patients' needs, but we're certainly hoping that'll get solved with time.
Pat or Juliet?
Yeah, so I I couldn't agree more with Clive. I would say that on your APC, so this kind of goes back to your fee for service talk a little bit, because you can't do a good job with behavioral health if you're worried about how you're going to get the patient in and out and perform a bunch of things on them, because behavioral health just it's not a great paying service that we can provide. So in the APC model, it works so much better. The other thing that works a lot better in this model is that because of telehealth and because of the increased access, we just can spend more time with patients. So we can, as physicians, we can actually be on a call with a patient and really focus on them for 30 minutes. And 30 minutes, if you go to a doctor's office and try to get 30 minutes of uninterrupted focus time, it's just really hard to do. So I think that this model really lends itself to being better for behavioral health issues. And just one quick anecdote, I believe so much in the link between your mental health and your physical health. And so for my own employees, I have 500 employees, and I actually hired our own counselor internal to our organization to allow my employees to, have that access. And what was so interesting, I figured, well, what's the worst thing that can happen if nobody uses her? Then I'll just use her in the clinics, for people who need it. But the first day that she came on, she was booked for like 2 months. And I thought my own employees would never, sign up for their employer paid. Like I could see, who she was seeing, and they didn't care. They just really wanted to have that opportunity to talk to people. And so if you're on this call and you're an employer and you don't think that your employees really would appreciate more opportunity to get in front of somebody who can help them with those kind of issues, I was very surprised. I was actually shocked. And so that has become something that we know is a very big part of what we provide in our model.
Very good. Pat, I know we've had some conversations about this and where Kelsey Siebold is, and I know you're taking some positive steps to work on this.
We are, yeah. We've talked about this many times, and one thing that strikes me, like in our system, everybody's insured. So our patients, they all either have commercial insurance, good insurance, or they're in Medicare Advantage. So both of those are very complete, comprehensive forms of insurance. And yet we are talking about, and this has been going on for a long time, a big problem in the behavioral health delivery system. So Clive, you and I are probably in the same age range, I would imagine, but I'll tell you what, when I trained as a family physician, we did get trained in taking care of common mental health disorders, anxiety, depression, ADD, those sort of things. But I don't think I realized how much behavioral health I was going to wind up doing as a primary care physician over the years. And for two reasons. One is because the medications have gotten better. I can certainly prescribe medications just like a psychiatrist would. I don't do the counseling part, but a lot of patients don't want to do counseling. They'd rather take a pill, and that's fine if that's the way they want to approach it. But the other problem is patients won't go to behavioral health. They will not go somewhere. If I try to refer someone to a psychiatrist, it misfires more often than it hits. And it's because it's not necessarily that there's anything wrong with psychiatrists, but people don't like the stigma of going. The behavioral health networks, I think, are not particularly well run. I was working our weekend clinic a couple of weeks ago. I had a college kid came in very significantly depressed. I'm like, well, I need to get you started on something, but I want you to see a psychiatrist. And my nurse was on the phone for half an hour before the health plan would pick up. It's that sort of stuff there's a real disconnect in the behavioral health world. A lot of psychiatrists don't even take insurance, so it's hard to even find them sometimes. So yeah, we've reintegrated behavioral health into our system. When I started at Kelsey, we had a psychiatry department. Due to health plan sort of stuff more than anything, we wound up not continuing that, but now we're getting back into it. And when you take care of a population of patients, a lot of what we're trying to do in the behavioral health community now regarding primary care is to make sure that people aren't falling through the cracks, that if somebody's not coming in for follow-up on for their behavioral health problems, that we reach out and try to get them back in, which is something that has not been done a great deal in my point of view in the behavioral health community in general. So a lot of times I think the behavioral health folks feel like, well, if they don't want to come in, you know, that's their decision. And you can't really do that in a population care sense.
Yeah. Andrea, in your plan, I think you mentioned that behavioral health is part of your solution. Have you seen evidence that it's making a difference?
Yeah, a lot of the primary care groups typically have a mental health person on site too. So if there's an issue that's identified perhaps during the primary care visit, they would refer them over, or they can make a direct appointment with that. So having that all in one place is really nice from the employee's perspective. Easy, whatever is easy is better. So making it as easy as possible for them, so they're not having to, I know everybody probably has an EAP program, but those can be a little cumbersome in terms of getting the code and finding someone in network. It's nice to just have that all embedded within the same place.
Yeah. I totally agree. And Pat, you know, the access and going to a psychiatrist, it's one of the things that we support this collaborative care, because the psychiatrist is usually retained on a consulting basis and is not needed except to address some issues that the PCP may feel uncomfortable with. And so we think it's a good model, and we're going to continue to support that. Another, to me, this is really important. We've learned this from the RAND studies we're doing. And I mentioned employers routinely paying 2.5, 5 times in our market, the Houston market, relative to Medicare. And what we're seeing is most of that is not due to professional services, it's due to facility fees. And it really takes a strain on all. And so a key element of advanced primary care is effective referral based on price and quality with what we have right now. And do you see some hope in the future where other than, and I know all of you do a great job of keeping people out of the hospital, but when they need a hospital, when they need a specialist, how was that done? And let me, I've shared this story before. I've had 10 orthopedic surgeries, all athletic, and the last one I had was a torn ACL, and I knowingly went armed with my MRI to 3 different physician groups or health systems, and I got 3 totally different responses. Long story short, ultimately I went with a conservative model. I didn't have the surgery that was recommended. I had to be in a boot for a while, but I didn't miss any time off from work. I didn't cause expense to the system. So what do you see as the role of the primary care physician in this model of effective referral to specialists when needed?
So I can talk about Kelsey-Seybold. We're a multi-specialty group practice, so we all work for the same organization. And by and large, you know, if I'm referring to a specialist, that I will refer to one of my partners in Kelsey-Seybold. And the reason that I'm comfortable doing that, and I think it shows up in our quality measures and in our total cost, is that we basically vet everybody who joins our group. So the sort of conversations we're having now about fee-for-service medicine, evidence-based care, you know, the idea of advanced primary care, we talk to all of our doctors, both primary care and specialists, when they consider joining our group. And one of the things I tell them, again, in my 3-hour dissertation that these poor docs have to go through, is that if you remember nothing else about what I'm telling you, just practice evidence-based care. Evidence-based care is a common term. It's well known in the medical community. I don't know if our audience is all that familiar with it, but basically what it means is that you follow national guidelines. You follow the evidence that if something has been shown to help a patient, you do that. If something has not been shown to help a patient, but you can make a lot of money doing it, you don't do that. So it's that simple. I know that our specialists are cost effective. They are evidence-based. They have high quality of care. Chris, I know that you were a Kelsey Siebel patient for a long time. And so individual results, individual patients, it's not unusual you get more than one recommendation. And that's kind of within the art of medicine, I guess, part of that. But I know that overall, as a group, our cardiologists, our orthopedists, gastroenterologists, you name it, they are all inculcated in evidence-based care. So I'm confident that, and I know these folks, plus I can see everything they're doing. We're all in the same electronic medical record, which is like, it was like going to the moon when we got that thing, because it's just so much better than the old paper chart. But I can see everything that they're doing. We can communicate really well. When they do go into the hospital, I can tell what they're doing in there because I can see the whole chart. So that's kind of where we come from in our style of practice, which is multi-specialty group practice.
Juliet, Clive,
Actually,
comment?
yeah, so we have a slightly different model. So the people that become clients of ours are very interested in direct payment for services. So basically no insurance company, they're paying for their care. That makes them very interested in also any other direct relationships that we can help them with. So with several of our clients, what we've done is we've gone out and contracted some bundled rates for some procedures. And what we do is with our care navigation, we let the patient know your employer has chosen to pay 100% if you choose to, for instance, have your CT scan here or have your, orthopedic surgery here. But you can also use your insurance plan and go anywhere that you would like. That's in, when we give them their in-network choices. So our care navigators are gently guide people, but they will actually make the appointments and the referrals for wherever the patient wants to go. So there's a feeling that we're not blocking people from choice, because people really get, especially here in the United States, we're all about, free choice. So we want to make sure that we're not making people feel like they have a narrow network, but they do have the option for a totally free experience with the contracts that we've put together. So there's that. I think on the referral in general, one of the things that we've figured out is that we can save employers a lot of money by just having specialists back up. And I'm sure that Kelsey does this routinely. We have orthopedists on staff. We're actually making deals with dermatologists so that when a patient sees us for primary care, we have kind of like a quick curbside consult with a specialist that is not a visit and doesn't incur a lot of cost. We are actually paying those people to take those calls, and we can avoid a lot of unnecessary referrals. So those specialists know that their job is to say 100%. That is not going to heal with a primary care doctor. It has to go to someone else. But there are so many times when, primary care doctors are busy or are maybe they're just personally not educated enough to know that this could be handled in this particular way. So we have specialists backing up and giving that advice.
Thanks. Mary Ann, were you about to cut us off?
Well, I'll give you one more minute just to thank your panelists.
Well, that's.
I hate to make it end. This is so great.
Yeah, we could talk about this for a bit, but I can't thank. I just amazed by the questions. There are a couple we didn't get to answer, and I'll ask those individually and see if we can get those answers to you. But I hope for those and the number of participants grew the entire time. I hope that we've made the case for your organization to consider advanced primary care in your benefits design getting away from the standard PPO, bypass the primary care physician, go direct to specialists. There are opportunities out there, but you've got to do something a little bit different. So, and Andrea, thank you so much for sharing we'll follow up with what you're doing in Plano. Really can't thank everyone enough. So again, God bless and appreciate it.
Yeah, and my
Should we all get off now, or?
My thanks to you, Chris, for putting together such a great panel, and to all of your panelists. As I said, the program, the session has been recorded, and this particular infographic that you showed is excellent. We will post that on our website because I think it's just a really, really important one in our resources. So thanks for bringing it to everyone's attention, Chris.